Good morning, everybody. So, the management of placenta accreta spectrum begins from the time it is diagnosed. A definitive diagnosis of placenta accreta is usually made around around the time of TIFA. And the single most critical, the most important step of placenta accreta spectrum management is counseling. So, the counseling should never be taken as a simple thing. The counseling for these patients must be both practical and emotionally supportive. So during the counseling session, we need to discuss in detail about the concept of placenta accreta, its consequences on the mother and the fetus, and the management options during pregnancy. So this needs to be done as soon as placenta accreta is suspected, and we should not keep it for the later weeks of pregnancy. And the counseling also needs to be personalized. We need to talk to the patient according to the diagnosis, in the sense that counseling for a case of focal placenta accreta would be different from how you would counsel a case of diffuse placenta percreta with organ invasion. And during these counseling sessions, we also take into account the best estimate of risk. We also talk to them about the potential for morbidity, including a possible threat for future fertility. And a small but definitive risk of mortality also must be discussed, because in the era of modern obstetrics, the possibility of a woman dying during pregnancy and delivery is largely unexpected, but we have to talk to them about that also. Now, management of these cases involves a multidisciplinary care team which consists of experienced obstetricians, urologists, interventional radiologists, obstetric anesthetists, critical care experts, and neonatologists. There has to be an access to a blood bank which is capable of employing massive blood transfusion protocols, and there also has to be a well-equipped ICU to optimize hemodynamic status, correct electrolyte imbalances, and minimize target organ damage. Studies have clearly shown that delivery of these patients in a center with a multidisciplinary team shows a significant risk reduction. There is almost a 50 to 80% risk reduction in the morbidity and mortality of these cases when they were performed in a center equipped for the same. Because the main risk in these patients is obstetric hemorrhage, we need to optimize their hemoglobin levels well before delivery. So starting from the early third trimester, we have to see that the hemoglobin levels are maintained at or above 11 grams per deciliter. And in case it is not so, we rely on IV ion formulations rather than oral iron. Now coming to hospitalization. We know that these patients are at high risk of preterm labor, pre-PROM, and recurrent bleeding episodes throughout pregnancy. So we have to consider inpatient management starting from the early third trimester. But again, this can be individualized based upon the proximity of the patient's residence from the hospital and availability of transport. But whatever it is, whether it is inpatient or outpatient management, effective communication between the patient and the team must be the priority. Now moving on to delivery. A scheduled delivery is always better than an unscheduled delivery in these patients, because unscheduled delivery is definitely associated with a higher risk of morbidity. Coming to the timing of delivery. Way back in 1996, O'Brien et al. In his study clearly showed that after 35 weeks of gestation, 93% of patients with placenta accreta experienced hemorrhage that was severe enough to necessitate emergency delivery. And another study also showed that planned delivery at 34 to 35 weeks of gestation in these patients did not increase neonatal morbidity. So taking this into consideration, guidelines advocate for delivery of these patients between 34 to 36 weeks of gestation with a corticosteroid cover. Now, because these patients are prone for hemorrhage, we have to prepare for massive blood transfusion in the pre-op period. The average blood loss in these patients is anything between 1.5 to 5 liters. So at the minimum, we have to keep 6 PRBC, 6 FFP, and 6 unit platelets ready before starting the case, with facility for more if needed. Coming to peri-op management, on the day of surgery, we need to obtain adequate IV access. At least 2 large bore IV cannulas must be placed. Use of direct invasive arterial monitoring will help in managing the fluid administration. And the presence of an anesthetist who is accustomed to managing obstetric hemorrhage, rapid large volume transfusion, and invasive hemodynamic monitoring is crucial for these cases. Use of thromboembolic deterrent stockings, padding and positioning to prevent nerve compression, avoidance and treatment of hypothermia are all integral part of peri-op management. The anesthesia preferred is general anesthesia because of the anticipated prolonged surgical times, and also that we have better hemodynamic control, and that is what the American Society of Anesthesiologists recommend, with an epidural catheter for post-op relief. Patient positioning depends upon the surgical approach, but usually the positioning should be such that it should allow for good surgical exposure for a large laparotomy, space for rapid intubation, and placement of multiple arterial and venous lines. A leftward tilt is placed till the fetus is delivered, and there also has to be access to the perineum so that we can periodically address blood flow from below. So for this, a dorsal lithotomy position with a left lateral tilt would be ideal. Coming to use of ureteric stents, performance of cystoscopy and placement of ureteric stents is usually done only when we are suspecting bladder invasion. That is in cases of percreta and not as a routine. Now moving on to surgical management. High quality comparative data to determine what is the best surgery for placenta accreta spectrum, still we are lacking. So because of this, dozens of approaches have been described, but broadly we can categorize it into 4 groups. So the first one is in situ caesarean hysterectomy. The second is conservative or expectant management, keeping the placenta in situ. Planned delayed hysterectomy weeks after in situ management. And partial myometrial resection and uterine reconstruction. The fifth method, which is the extirpative method, it used to be done once upon a time, where after delivery of the fetus, the placenta would be forcefully removed from the uterine wall. It's no longer being done because of the torrential hemorrhage and high degree of mortality with that procedure. So the first approach, the caesarean hysterectomy, is the most common approach, most appropriate approach, especially when the patient is hemodynamically unstable and actively hemorrhaging. It is the default backup plan when other strategies fail. However, caesarean hysterectomy performed in the technique of in the setting of placenta accreta spectrum is complex and hazardous, mainly because of the high degree of vascularity and also because of the altered anatomy. The lower uterine segment is very much distorted in these cases. The uterine vessels, ureters are all aberrantly located, and there's also a distorted bladder, plus the fact that these patients have had prior uterine surgeries. So there is a lot of additions. So all this makes the whole procedure very technically complex. So what are the techniques that we can adopt to minimize blood loss during these surgeries? The first one is to have a good midline incision so that we have a good exposure, and also for pelvic dissection, exposure is good. Then we try to make an incision well away from the placental site so as to avoid placental disruption, which will aggravate bleeding. Aggressive use of uterotonic agents, stepwise surgical devascularization or using of, even before the hysterectomy is begun, we can do a stepwise devascularization and place hemostatic sutures and then start. Or the use of pre-op balloon occlusions. The hysterectomy usually done in these cases is a total hysterectomy, especially when there is a placenta previa. In certain cases of focal placenta accreta in the upper uterine segment, we can consider a supracervical hysterectomy. In case there is bladder invasion, we do what is called a posterior retrograde hysterectomy. So here what we do is, after the baby has been delivered and the hysterotomy incision closed, the uterus is exteriorized, the round ligaments are clamped, cut and ligated, then the retroperitoneal space is opened and the ureters are dissected. After that, an assistant uses a sponge on stick and then pushes the posterior fornix from below, and the POD is opened from above. Then the vault is circumscribed all around, and then using a sponge holding forceps to hold the cervix, we begin the hysterectomy from below. That is the uterosacrals, the cardinals, then the uterine vessels. After this, the vesico-uterine space is opened. If there is a placenta percreta, the vessels are all ligated, and if there's obvious bladder invasion, then a cystotomy or a partial bladder wall resection can be done. So this is a procedure adopted when there is a bladder invasion. Any of these cases have the following complications. The median blood loss is about 1.5 to 3 liters, necessitating large volumes of blood transfusion, genitourinary tract and bowel injury, ICU admissions, thromboembolic complications, SSIs, reoperation, and the risk of maternal mortality. Second method, conservative in situ management. In this method, after delivery, the cord is tied off near the incision is closed, and if there's no bleeding, we close the abdomen and we wait for resorption of placental tissue on its own. The rationale behind this method is that following delivery, there's a progressive decrease in blood circulation to the uterus. This causes secondary necrosis of villus tissue, causing the placenta to either detach or resorb. And adjuvant methods like embolization, vessel ligation, internal iliac artery balloon occlusion, methotrexate, hysteroscopic resection of tissues, these have all been used to accelerate placental resorption. Among these, the methotrexate is no longer used because of both its lower efficacy as well as higher toxicity, even with a single dose. So generally, if we do this method, it takes almost 6 months for the placenta to get resorbed. So till then, we initial 2 months, we do weekly beta HCG monitoring, and as long as the levels are falling, it is reassuring. So after the initial 2 months, we switch over to monthly monitoring, and till complete resorption of the placenta. The advantage with this method is that it decreases the surgical morbidity and also the bleeding. Studies have shown that it is successful in almost 78 to 94% of cases. But the data available are from a very small group of people. And the concerns in these patients are the risk of emergency surgery due to life-threatening bleeding or uterine sepsis. Patients living far away will have logistic issues. Cost barriers again, because insurance will not cover additional care. Some may not be willing to accept the burden of prolonged follow-up and also the uncertainty around this kind of management. Moving on to planned delayed hysterectomy. This method was proposed as an approach to minimize risk associated with both immediate hysterectomy and the risk associated with prolonged conservative management. So what we do here is after opening the abdomen, we evaluate the uterus, bladder, adhesions, pelvic organ involvement, all that. And then if you think that a safe hysterectomy can be performed, you go ahead and do it. But if you feel that the hysterectomy might be risky and associated with a lot of bleeding, then we close the abdomen and do the hysterectomy a few weeks later when the bleeding risk is low. So studies have shown that this method is associated with a lower blood loss, fewer transfusions compared to an immediate hysterectomy. However, this requires 2 planned surgeries, so longer surgical times and longer post-op length of stay. Partial resection and uterine reconstruction. In selected cases, we just resect the placenta and attached myometrium, followed by repair and reconstruction of the remaining uterus. Factors favoring success of this method are that there must be sufficient viable tissue around the affected area. Depends upon the location and severity of pelvic adhesion. So we can do it in a few cases of selected focal placenta accreta. The ACOG states that this approach should be individualized. One such method is a triple P procedure, which was popularized by Sabaratnam Arulkumaran and Chandraharan. The 3 Ps are preoperative pelvic devascularization using intraarterial balloon catheters, periop localization of the placenta and incising above it. Then, without separation of the placenta, we go ahead, excise the myometrium and reconstruct the uterus. The TURIP procedure is another procedure. Here, a hysterectomy is done, baby is delivered. After that, we place a tourniquet around the uterine vessels and then give nitroglycerin, invert the uterus inside out, sharply dissect the placenta from the underlying myometrium, repair the myometrial defect, and then put back the uterus into its original position, remove the tourniquet, place a balloon tamponade, secure the angles and close the uterine incision. So this all has been tried within few cases. But we must remember that whenever you do such kind of uterine reconstruction, it's a badly scarred uterus. So there's a high risk of adverse pregnancy outcomes such as recurrent placenta accreta, uterine rupture and preterm birth. Now what do we do if we face a situation like this, an intrapartum diagnosis of placenta accreta? It depends on the center that you're working in. If you're equipped with adequate resources and expertise, you can deliver and then proceed with a hysterectomy. Otherwise, if the patient is stable, simply close the abdomen and refer the patient to a higher center. In case we encounter an adherent placenta following a cesarean section or following a vaginal delivery, then also it's the same thing. If the patient is stable and your center is not equipped, you close the abdomen, uterus and abdomen and shift. Otherwise, you manage in your center by doing an emergency hysterectomy. So I conclude by reiterating that cesarean hysterectomy is still the gold standard. In our hospital, in the last couple of years, after we had an interventional radiologist, we've used their services in 7 cases, and out of them, 4 has worked. So this is one such case. This is a small video, a 1-minute video. It's not playing, huh? Just read it. So in this case, we could manage without using a single unit of blood because they had cannulated the iliac vessels. Thank you all for your patient listening.
Thank you so much, ma'am. I now